Good evening. I'm Psychiatrist Jay Fawver, and welcome to Matters of the Mind. Matters of the Mind is a weekly mental health program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. That's Matters of the Mind at WFWA.org. And if you are able to do so, you may call or text me during this program. Let's start this program with an email I recently received. It reads, Dear Dr. Fawver, I thought I saw it there a minute ago. Here we go. Is tardive dyskinesia something I should worry about? I've been on Effexor, that's also known as venlafaxine, and Wellbutrin, also known as bupropion, since 2024, but prior to that I was on Prozac for about 10 years. I'd like to stay on my current medication of Effexor and Wellbutrin since it's working well. Well, that's fantastic. Since it's working well, you certainly want to stay on the combination of Effexor and Wellbutrin. Effexor basically increases the neurotransmission of serotonin and norepinephrine. Wellbutrin's increasing neurotransmission of norepinephrine and dopamine. So in essence, you're getting the enhancement of norepinephrine, serotonin, and dopamine. Good combination overall. Tardive dyskinesia is a condition in which you may hear over the television commercials because there's a couple medications that are FDA approved for the treatment of tardive dyskinesia, Austedo and Ingrezza. Now, these medications basically will treat people who have tardive dyskinesia related to tight dopamine receptor blockers. Those are also known as antipsychotic medications. Antipsychotic medications in this decade have been used predominantly for people who are having mood disturbances, who are better but they're not well. So antipsychotic medications can help an antidepressant work better for a mood condition, but inherently, antipsychotic medications can be tight dopamine receptor blockers. If you tightly block dopamine receptors in the brain, you can bud out more dopamine receptors, and that makes your brain supersensitive to dopamine. What happens then, if your brain becomes supersensitive to dopamine, you'll get twitches and tics, even throat crunch, you'll get respiratory gasp every now and then. You'll get these symptoms that are quite bothersome for a lot of people, and those are the symptoms of tardive dyskinesia, and that will be what Austedo and Ingrezza will treat. So, with that in mind, will Prozac, over the course of 10 years, will Effexor, Wellbutrin contribute to tardive dyskinesia? Not typically. Now, I say not typically because if you increase serotonin, as Prozac will do, inadvertently you can decrease transmission of dopamine, but you're not actually blocking dopamine receptors. So theoretically, with Prozac long-term, while you're taking it, you could get extrapyramidal symptoms, which are also known as Parkinsonian symptoms. Those symptoms are characterized by a tremor, shuffling gait, stiffness. If you have extrapyramidal symptoms early on with an antipsychotic medication, that is predictive later on that you could get tardive dyskinesia, especially if you get those symptoms at an early age. Now, generally, Prozac wouldn't cause those kind of symptoms, but with Prozac, Effexor, Wellbutrin, you're not blocking dopamine, you're decreasing it slightly with the use of Prozac. You're actually increasing dopamine with Wellbutrin, so I wouldn't be concerned about the possibility of tardive dyskinesia with Effexor and Wellbutrin. My goodness, if you're doing well from an emotional perspective with that combination, it can be a very safe medication combination that you indeed can take long term. What are the possible adverse events from the combination of Effexor and Wellbutrin? Slightly, you can have an increased likelihood of high blood pressure because both of them are enhancing norepinephrine, and Wellbutrin especially is increasing norepinephrine and dopamine. Wellbutrin has about half the potency of a stimulant medication. So a stimulant medication would be something like Ritalin or Adderall or Vyvanse. These are stimulant medications. Wellbutrin has about half the potency of a stimulant medication. Stimulant medications can indeed increase blood pressure. Wellbutrin can, but not so much. So as long as your blood pressure is okay with Effexor and Wellbutrin, really good combination. They don't interact with each other adversely. They don't interfere with either metabolism. So that could be a combination you could continue long-term without the fear of tardive dyskinesia. Thanks for your email. Let's go to our first caller. Hello, Peter. Welcome to Matters of the Mind. Peter, you want to know, is it possible to become immune to antidepressants? We have a fancy term for that called tachyphylaxis. Some people just flat out call it poop out, Peter. So people can kind of have a poop out effect from their antidepressants, particularly the antidepressant medications that will increase serotonin. And these medications can include Zoloft, Prozac, Lexapro, Celexa, Paxil, and Luvox for that matter. Sometimes they will work for a while, and they'll give you a little bit of an emotional numbing effect which is a side effect of those medications. But if you increase serotonin, indirectly you can decrease dopamine. If you decrease dopamine, many people will notice that they feel the emotional blunting effect, but then they can have difficulty with enjoying things. They have trouble with motivation, get up and go, and they just say, my antidepressant quit working. Now, 20, 30 years ago, the makers of Prozac just said, well, you just need to increase the dosage. We quickly discovered that that's the last thing you want to do, because if you increase the dosage of a serotonin-like medication, that can actually make matters worse. So we now know that long-term use of a serotonin antidepressant medication for some people can cause them to have kind of a poop-out effect. Now, we've also seen that with some of the other so-called monoamine antidepressant medications, the antidepressant medications that affect serotonin, norepinephrine, and dopamine. These medications sometimes will kind of lose their effects over the course of time. So we're looking at ways of developing medications that will give you longer-lasting effects where you're not just better, but you're well. Because we do know that if somebody gets better from their antidepressant, but they don't actually get well, they have simmering, lingering symptoms that are persisting, they're more likely to have a relapse and recurrence of depression itself. So we want to put out the campfire of depression so that you don't get any puffs of smoke firing up that campfire. We want that depression to be totally extinguished. We don't want any lingering residuals, burning embers going on in there with depression. So we want it entirely extinguished so that people are less likely to have perhaps a minor or even a major stress in their life flare up that depression itself. Thanks for your call. Let's go to our next text caller from Fort Wayne, Indiana. We have a question about anxiety and allergy medications. The question being, what can help with anxiety and allergies when allergy medications tend to make the anxiety worse? And does any of that cause neuropathy? Anxiety medications typically would not cause neuropathy. Allergy medications would not typically cause neuropathy. So that's a whole different phenomenon where you might have burning and numbness and tingling in your lower legs and arms for that matter. Now, what do you do if you feel anxious with medications used for allergy? I think you might be talking about sedating antihistamine medications such as diphenhydramine, or also known as Benadryl. Benadryl has two features that can make some people anxious. Number one, it does get about 80% about 50 to 80% crossing into the blood-brain barrier. So Benadryl or diphenhydramine does get to the brain and can make you sedated, but it also has an anticholinergic effect. An anticholinergic effect is basically where you're blocking acetylcholine. If you block acetylcholine, for some people that can make them kind of anxious. So blocking histamine and blocking acetylcholine in the brain, which is what diphenhydramine or Benadryl can do, for some people it can make them anxious. So number one, I think if you're going to take an antihistamine medications, you'd want to take something that has minimal carryover into the brain itself. In other words, it would not cross the blood-brain barrier. And those would be medications like Allegra, Zyrtec, Claritin. Clarinex is the active breakdown product of Claritin. These medications don't cross into the blood-brain barrier so much, and they wouldn't give you as many side effects such as anxiety. Clarinex, as opposed to Claritin. Clarinex is the active byproduct of Claritin. Clarinex tends to last longer and it's more potent for people. But those medications typically would not cause a lot of anxiety. And I want to stay in my lane as a psychiatrist, but there's a lot of other medications out there for allergies. There's the nasal steroid medications. There's the leukotriene receptor antagonists such as Singular. These medications work in entirely different ways than the traditional antihistamines. So there's a lot of other options out there for treating allergies. So you need to talk to your primary care clinician, your allergist, whoever you may be seeing for allergies overall. Thanks for your text. Let's go to our next text. Hello, Tom from Columbia City. You have a question. Why is exercise helpful for managing mental health? It's an interesting phenomenon, Tom. If you've ever exercised, you don't want to go there a lot of times, but you leave the exercise facility and you find that you're energized, but you're calm at the same time. And it's rare that anybody leaves a workout after 30, maybe 45 minutes or so, and they wish they hadn't done it. That's rare that's ever going to happen. If you did, you hurt yourself, you overdid it, something happened. But most people, if they exercise to a moderate degree, they feel pretty good. And the reason you feel pretty good after exercising is two things happen. We've got the accelerator neurotransmitter in the brain called glutamate. Glutamate is like pushing on the accelerator. GABA is pushing on the brakes. Glutamate and GABA, it's like a teeter-totter. They should be in balance in the brain. So glutamate's the accelerator, GABA is the brakes. When you exercise, Tom, what will happen is both glutamate and GABA increase. So you feel more energized and you feel calmer from an emotional standpoint after you leave. Now, there's all these benefits you get from exercising with the muscles, and you get all these anti-inflammatory effects that can occur with exercising. So there's a lot of good things happening there, but really from an emotional standpoint, you're increasing glutamate and GABA concomitantly. When you increase both, you feel better, and that good effect on your mental health will continue for a day or so. That's why it's good to exercise ideally about 5 days a week, 30 minutes at a time. We used to think, gee, if people had really hard workouts for an hour and a half, maybe 3 times a week, that's all they'd need. But generally it's thought that if you have more moderate exercise sessions, maybe 5 times a week, that's going to be better for your mental health overall. Now, why wouldn't everybody exercise if they have depression or anxiety or any mental health problem? Well, the problem is exercising requires you to have motivation, energy, initiative. You need to get out the door and into a facility or into a place where you can exercise. And you can exercise with walking too. Increasing your steps is fantastic. Simply walking can be very, very helpful. But for a lot of people, what they're needing is the resistance training. That's also known as weight workouts. People hate hearing about that. But if you do resistance training or weight workouts on machines, dumbbells, barbells, they are very, very good, especially as we get older, because as we get older, we tend to lose muscle mass. So you tend to lose muscle mass as you get older. It's a very, very important to maintain strength training as you get older, and maintaining that strength training will enhance the transmission of glutamate and GABA in the brain. Thanks for your text, Tom. Let's go to next text. Hello, Erica from Marion. You asked, I have a grandchild who has severe attention deficit hyperactivity disorder and Tourette's. Recently, he has started having bad breathing tics. That kind of goes along with Tourette's as well. He is being treated for the ADHD. What would you recommend for the breathing tics? Usually with the breathing tics overall, you're going to treat somebody who has Tourette's with ADHD with the alpha-2 agonists such as guanfacine or clonidine. You're going to be hearing about those type of medications. Those are old blood pressure medications that are often used for breathing tics, Tourette's, and for the inattentiveness, the distractibility, and the impulsivity associated with ADHD. So guanfacine comes in a long-acting form called Intuniv. It's now generic. Clonidine is more sedating, but it's very powerful. You typically take it at bedtime. It often can help with sleep. But between guanfacine as a generic chemical name and clonidine, those are the main means of treating some of the Tourette's and breathing tics, as well as ADHD. Now, you've got to be careful with the ADHD aspect of it, because stimulant medications can enhance the symptoms of tics, Tourette's, and twitches, and all those other things that go along with it, because those can be side effects from stimulants. So you got to be careful if you're going to use a stimulant for ADHD. There are now several non-stimulant medications that have become available that may be less likely to aggravate the Tourette's syndrome symptoms, as well as the breathing tics overall. Thanks for your call. Let's go to our next email question. Our next email question reads, Dear Dr. Fawver, if someone has been on many of the psychotropic medications in the past and they're reluctant to take anything, how do you encourage them to resume any medications? Well, the first thing I'd want to know, if somebody's been on a lot of different medications, I'd want to know what medications they were taking, how long they took them, very importantly, why they stopped them. Did they stop them because they felt okay and they didn't feel like they needed them anymore? Did they stop them because they had side effects? Did they stop them because they didn't work? So I would want to systematically look at what medications somebody took previously. Now, sometimes people will kind of recognize names and they'll put them together. Many times we as clinicians can look in somebody's electronic medical record and we can actually see electronic medical records from other facilities and other clinicians if we're all on the same electronic medical record system. So that's getting easier to do now, and we can look into the past medical records and see what somebody might have taken, but I would want to know systematically the mechanisms of action. I'd categorize all the different medications somebody's taken and see if I could get a picture of what might have worked, what might not have worked, and start from there. And sometimes I'll simply ask a patient, what of all the medications you've taken seem to help you the most? And kind of start from there and figure out, okay, if they did well with this medication or that medication, we can go back to that medication and sometimes add something to it. Now, many people will say, I've been on everything. Well, there's about 130 medications we use now in psychiatry, so you probably haven't been on everything. You've been on a lot of things maybe, and you've taken medications perhaps that have overlapping mechanisms of action. I mentioned earlier the serotonin medications, Prozac, Zoloft, Lexapro, Celexa, Paxil, Luvox. Those medications, they all work kind of the same. They have subtle differences, but if you failed on one or two of them, you probably shouldn't be taking a third one or a fourth one, but that's often what occurs. So people will go from one medication to another to another. I'd also want to know not just what medication somebody's previously taken, but what are we treating? Sometimes you just have to step back and think, okay, what are we treating here? And have people been going down the right track from a diagnostic standpoint? Because, for instance, if you have difficulty with poor concentration, fatigue, lack of initiative, do you have sleep apnea? Do you have low iron? Do you have diabetes? Do you have thyroid disturbances? There's a lot of other things we consider when somebody's not feeling well. So sometimes we have to look at other comorbid medical conditions. Sometimes we'll look at what other medications they might be taking for other conditions. I mentioned earlier a leukotriene receptor antagonist by the name of Singular, used for allergies, but it can sometimes, just sometimes, cause people to be more depressed and have trouble concentrating. So if I happen to see that they're on Singular and I look back and say, well, gee, I started feeling lousy about this time or that time, we look at when they might have started taking a medication like Singular or some other medication like it, because sometimes other medications can make people feel lousy, and we always go back to when somebody started feeling lousy and see if there's any correlation to what medications they might have been taking. So we want to systematically look through all that. So if somebody's reluctant to take medication, I want to know why. Is it because the medications they've tried didn't work? What lingering symptoms are they having? Are they having side effects from the past medications? In which case you need to go another direction. And finally, I'd want to know what kind of symptoms, if any, are they perceiving still need to be treated? Now, some people will say, I'm fine with just treating my symptoms with recreational marijuana. That's fine. Well, that's up to you one way or another, but other people might notice it's causing a problem because maybe you're not as productive at your workplace, maybe you're not as engaged in different relationships with other people, maybe you're more withdrawn, you don't have the motivation. Cannabis as a drug can cause lots of side effects itself, and number one, at the very, very top of the list, it just makes people not care. And that's the biggest concern I have about recreational use of marijuana. Yeah, it can help with anxiety for some people, can help with sleep, can help with pain in some ways, but is it causing a side effect that's not allowing you to be all you can be and causing you to be functionally impaired for that matter? So I'd want to know what kind of goals a person who's reluctant to take psychiatric medication is trying to achieve. And why do you think, as a family member, a friend, why do you think they need the psychiatric medications? So at some point, it'd be nice for you to compromise with that particular individual and sort out, what you're noticing, and they can say what they're willing to treat one way or another. Thanks for your call. Let's go to our next caller. Hello, Leah. Welcome to Matters of the Mind. Leah, you want to know, are stimulants safe to take during breastfeeding? There are some stimulants that are safer to take during breastfeeding, Leah, methylphenidate products, Concerta, long-acting Ritalin products. They can be safe during breastfeeding because they don't tend to cross into the breast milk so much, hardly any at all. But the first question I'm going to ask for somebody who's breastfeeding is, okay, you're breastfeeding, maybe you're an at-home mom, maybe you're going back to work. What are the main goals you're trying to achieve? If you're simply saying you want a stimulant during breastfeeding because you want more energy, well, yeah, everybody wants more energy after they've delivered a baby. Number one, my first question is, are you suffering from postpartum depression, which will zap you of your energy itself? We have very specific medications that we can use for postpartum depression. One in particular called Zurzuvae that actually mimics allopregnanolone, which is a byproduct of progesterone. Excuse me. Allopregnanolone will give you the hormonal type of analog, the mimicking of progesterone, such that you'll have the relief of postpartum depression in many cases within 2 weeks of treatment of the Zurzuvae. So if you're looking for the treatment for postpartum depression, I wouldn't go with a stimulant at that time. I'd go with something more like Zurzuvae. Other types of depression can be treated with Zoloft, sertraline, Wellbutrin. Remeron is also a medication commonly given while somebody's breastfeeding if they're having difficulty with postpartum depression as well. If you've had ADHD, maybe you're trying to go back to work, you're trying to function around the house, and you really are having trouble with concentration and focusing, methylphenidate products would probably be the best to use. But the key with methylphenidate products, you have to dose them appropriately. If you dose them too high, they won't work. It's like getting eyeglasses for somebody with nearsightedness, and the eyeglasses are too thick. If eyeglasses are too thick for you or corrective lenses are too thick, you've got to go with a thinner corrective lens. So maybe if methylphenidate hasn't worked for you in the past, maybe it was dosed inappropriately. Wellbutrin, bupropion can be used for ADHD symptoms for some people as a non-stimulant off-label use of ADHD. Amphetamine products can be used for ADHD, and they're not too prone to get across the breast milk. The biggest concern we have with amphetamine products, such as Adderall, Vyvanse, Mydayis, these medications can decrease prolactin levels while you're breastfeeding. You need high prolactin to be able to breastfeed. So amphetamine products can not so much get into the breast milk. That's not the issue. It's more that they can decrease the production of breast milk for somebody who's breastfeeding. So we have to look at all those different options. But number one, I'd want to know, okay, what are we trying to achieve here? What are the goals when you're thinking you need a stimulant and you're breastfeeding? Secondly, what kind of things are we trying to achieve and how can we work around that? And very importantly, what's worked and what's not worked in the past? Thanks for your text. Let's go to our next caller. Hello, Johnny. Welcome to Mayor's of Mine. Johnny, you're from Fort Wayne. You want to know, can music release dopamine? Yeah, music can have some beneficial effects, Johnny, because if you have any kind of activity, including listening to music, that increases your joy, your sense of happiness, yeah, that's probably dopamine work in there. So we often have people listen to music kind of in the background, and what we're trying to do is change their brain networking so they can actually concentrate better and decrease the outside distractions. So music can be helpful in terms of decreasing outside distractions, but indirectly, you bet, Johnny, you can increase dopamine and get joy and happiness if you're listening to something that's pleasurable. And it's for many people, if they listen to music that provided them good memories, and they can associate the music with good memories in the past, that music with those good memories can thereby increase dopamine too. So, yep, it's not something that's going to increase dopamine to the effect as medications or nicotine or various other substances out there, but music can subtly increase dopamine as well. Thanks for your text, Johnny. Let's go to our next email question. Our next email question reads, Dear Dr. Fawver, with the genetic testing being available for psychiatric conditions, can we test for genetics and proactively treat for such a condition? Genetic testing is available for various kinds of medical conditions, including psychiatric conditions. And when we look at genetic testing, yeah, there are genetic tests for various mental health conditions. Schizophrenia, for instance, has over 250 different genes that might be influenced that can lead to schizophrenia. Bipolar disorder, another condition, might have over 200 genes associated with it. So with genetic testing, you can see the genes that are there, and you might see that some genes are more likely to trigger into a certain condition. But think about genes as being light switches all around your house. If you think about all these light switches you have all around your house, the light switches need to be physically turned on to be able to activate the electricity and give you the light. And that's what happens with genes. Genes can sit there and genes can look pretty definitively like they're going to cause certain mental health conditions, but if they're not turned on, they're not as likely to cause that condition. For instance, you could have a lot of genes that might suggest that you might have the possibility of schizophrenia, especially if you have a first-degree relative with schizophrenia in your family. But you might have those genes that are there, but those genes need to be activated. You need to have early childhood experiences that are traumatic, maybe the use of marijuana. That can certainly activate genes for schizophrenia. So the genes can be there for various mental health conditions, but they have to be activated by trauma, by outside substances. Something needs to turn them on. We call that epigenetics. So genetics are one thing. Yep, you might have the hardware for those kind of things, but like any software and like any light switches, they have to be activated to actually turn on the underlying mechanisms that would cause the actual illness. Thanks for your call. Let's go to our last caller. Hello, Sally. Welcome to Matters of the Mind. Sally, you want to know, is it normal for your 8-year-old to have an imaginary friend? It wouldn't be considered to be absolutely abnormal for an 8-year-old to have an imaginary friend. The one question I would ask, Sally, would be that, does the imaginary friend hinder your 8-year-old's ability to socialize? In other words, if the 8-year-old's imaginary friend is causing the child to not want to socialize because maybe the imaginary friend is hindering or inhibiting him or her from being around other people, if the imaginary friend is telling the 8-year-old child to do something or not do something, that could be problematic. But having the company, the comfort, the means of bouncing ideas off of an imaginary friend is not considered to be abnormal for a child. Thanks for your call, Sally. Unfortunately, I'm out of time for this evening. If you have any questions that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. I'm Psychiatrist Jay Fawver, and you've been watching Matters of the Mind on PBS. God willing and PBS willing, I'll be back again next week. Thanks for watching. Good night.
The preceding program on PBS Fort Wayne is made possible in part by
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronHealth.com.